Good afternoon. I'm very honored to be here. Thank you very much for your very kind invitation. Thank you very much for being in this fantastic city of Cairo and sharing the development of transplantation with you. What I want to talk about is what I have been asked at the Transplantation Society, which is to take a look at the horizon. What can we expect and what are the important developments that are going on in transplantation in the near future? And every time one does that, there is an obvious subjective bias to this because there is many things that are going on in transplantation, and I have selected a few of them. One aspect I think I want to point out is that I feel that we somehow have neglected the organ in the way that we treat it, in the way that we assess it, and that goes back to some of what Marcelo has talked about. Can we resuscitate organs and use more organs for transplantation? And then there are some new aspects in transplant immunology, in the recipient treatment, that may offer new treatments for us. I want to start out by saying on what a privilege it is to be here. I think Egypt has contributed so much to science and to medicine, and interestingly, it has done so in a very integrative way. And that is, I think, very important for us not to forget, is that we are not only specialists, but that we really are working in a breadth of sciences and other aspects that we need to take care. And this picture here shows you a physician of the 19th dynasty who is reminiscent in the way he is depicted of the god of medicine, Imhotep, who was not only a physician, but who also was an architect who was the architect of one of the most famous monuments in Egypt. And for me, as a personal history, it is also interesting to be coming from a hospital where the first kidney transplant was done, and that is now 65 years back. Professor Haberwald had already mentioned that this was a milestone in transplantation, as it showed that transplantation is indeed possible, surgically possible. Dr. Murray went on with a lot of additional contributions, and for me it is wonderful to see on how transplantation has developed over those 65 years, and we have accumulated a lot of problems. We have solved many problems, but we have also accumulated of them, and I would argue those are all good problems that we have an opportunity to solve. Now this, in the lower portion of the slide, are data that compare patients waiting for a kidney transplant in the US. That is approximately 100,000 patients that are currently waiting, and in the US we do approximately 20,000 kidney transplants. Out of those, 1/3 are living donated kidney transplants. So there is a very obvious discrepancy between demand and supply. And that is coming back to what I said before, is that I think that we have not focused sufficiently on what we can do in addition by treating and assessing organs that are available. Here are some data that emphasize on what Marcelo has already alluded on, which is when we look for deceased donors at the overall availability of organs, then most availability is clearly in the age group of 50 and above. And what you will also see here on the very right side, there is also the highest amount of unrealized potential. So older donors really have a high potential, and I think we are underutilizing them. And the reason that we are underutilizing them, at least in our country, in the US, is that there is a very strong concern that we would not meet expected outcomes, and therefore there is a rather conservative approach in utilizing older organs. And Marcelo is very right by saying there is a missed opportunity. And this here are data that show you the relevance in a different way. This is from the Paris group, from Alex Lupi, and he looked, what Marcelo explained to you before, that there are different ways to categorize kidneys, and they are categorized more or less on a scale from 0 to 100. And he argues if we were to use all those organs now in different categories as shown here, we would overall be saving more than 100,000 years of functioning allografts if we were to utilize the organs that are available. So how do we get there? How can we make this happen? In addition to forming a network and a regulation and a disease donor program, how can we improve and assess the quality of organs? Now, organs, when they age, they go through broad ranges, and we summarized this here very recently, that there is an accumulation of senescent cells. That is a very important aspect, and I will come back to this, because the accumulation of senescent cells may indeed be a very important mechanistic driver of aging. There are products that are accumulating subsequent to injury, probably more so in older compared to younger organs. There's a bit more inflammation, and there are aspects in an older organ that may be just age-related and more challenging to change, such as aspects of an ongoing fibrosis or glomerulosclerosis, but that may, at the end, not be the deciding factor if those organs can be utilized for transplantation. We have done studies, and others have focused on that as well. We looked together with collaborators into the aspects of aging, of organ aging per se, and one of the driving factors here being the accumulation of senescent cells. Senescent cells are an interesting phenomenon. If we look into the overall turnover rate of cells, our cells turn over time, they are replaced. And there are two types of cells, in essence, that cannot be replaced: cancer cells and senescent cells. Senescent cells escape the phenomenon of programmed cell death, apoptosis. They just hang around, they produce bad products, inflammatory products, and by that they contribute to inflammation and aging. And what can be done is that the aging, the induction of senescent cells can be prevented with certain agents, with preventing certain pathways that activate those senescent cells, and they can be cleared. There are so-called senolytic agents, and senolytic agents are now in clinical trials. Those senolytic agents bring senescent cells back to their to be targeted through this program cell pathways and then be eliminated, and by doing that, really improving the quality of organs and prolonging graft life and patient life as well. And this is here shown in a very small experimental study when we pre-treated, those are mice, when we pre-treated mice with those senolytic agents, depleting the senescent cells from the graft, we did see a prolongation of graft survival, and that is only a very early step, and there are very many more therapeutic options that we may have. Now, there is obviously a dilemma if we try to play around with aging. We all do not want to age, and there is a physiological aspect in aging as well. And some of you may know the story in the novel of The Picture of Dorian Gray, where the proponent decided he didn't want to age, he only wanted his image, his painting to age. The story didn't end so well. So indeed, there may be another aspect that I think that may be important. If we transplant older organs, an aspect that we have not looked into is that we may also then transfer old cells and may then in a recipient accelerate aging. Now this sounds very theoretical, however others have done this. They have transferred senescent cells and have then seen that there was an augmentation of aging in those recipients of senescent cells. If this is at all relevant for transplantation, I think that is something that is unclear, but it is something that is in theory possible and needs to be studied. Now, talking about the graft and seeing what we can do with the graft, I think there is one very important development that we have to pay attention to, and those are the novel opportunities for organ preservation and the opportunity of assessing and reconditioning organs. Lung transplantation has spearheaded this process. The group in Toronto has moved ahead and has been very successful with this. And in the United States, there are now centers, organ repair centers, that indeed have defined their job by receiving organs, placing those organs on pumps. There are different pumps available. Organs can be pumped at hypothermia, at normothermia. There is a whole variety of additions that can be added to preservation solutions. I was talking about senolytics, but there are certainly many others. Then they are assessed, they get a quality check, and then they are shipped out again to another center. So that is really, I think, something that we will see a lot in the future, and I think that will have a lot of relevance for transplantation. Very rare that a clinical trial makes it into the prime journal of basic science, which is Nature. Even on the title, A Lifetime for Livers, that was Peter Friend's study of normothermic liver preservation. He took liver side by side, compared them, cold stored, normothermic preservation, transplanted them, and had improved results and improved outcome with the transplantation of organs that were normothermically preserved. This has also been shown for kidneys now, and there has been a very interesting clinical trial, and that is a report from China, where transplants, liver transplants, were performed in the absence of ischemia. A surgical technique that prevented ischemia altogether, and then transplanted livers without any ischemic injury. I think there is great opportunity in those areas moving forward. The mechanism of this is not entirely clear. Is it the temperature? Is it normothermia? Is it the oxygenation? This is a study by Pierre Clamien from Switzerland, showing that it is not the temperature necessarily, but the oxygenation. There are many studies that look into many aspects of that. Mechanisms are unclear, but the outcomes are very impressive in showing that organ preservation has a great potential. Talking about the graft, we have new ways to treat the graft locally, and that is through the application with therapeutic ways that then are localized in the graft. Nanoparticles are one of those approaches, and this is a study here that we have done together with Reza Abdi, treating organs with nanoparticle-loaded anti-interleukin 6, which is very important during ischemia reperfusion injury, and seeing a prevention of some of the consequences of ischemia reperfusion injury. Many grafts that are many cells that are in the graft that can be targeted that way, and new ways of local immunosuppression, local delivery may help us to be more efficient that way. Organ availability has gone different ways as well, and that is with the availability of new antivirals, we now have the opportunity to use organs from hepatitis C positive donors. Initially, that has been done for lungs and hearts. Now many centers do this for livers, for kidneys, purposely using hepatitis C positive donor organs, transplanting them, and with the transplantation applying antivirals, and though eliminating the hepatitis C virus, and really taking a great advantage of organs that we have not used before. And that is even more so important in our country with a terrible addiction and opioid crisis that we have, and many patients and many donors that are hepatitis C positive. And there's another aspect, I think, that has relevance for kidneys primarily, but I'm going to show you in a second for livers as well, which are paired kidney exchanges. Large registry that make it possible to match non-compatible donor and recipient couples. This here was at the time a New York Times front page articles of 60 lives changed. 60 lives changed, 30 kidney transplants, an entire chain that was initiated by one altruistic living donor. A great opportunity. The National Kidney Registry in the US has now performed more than 3,000 kidney transplants. You see here, there is a rising amount over the years of paired kidney donors. This is the triangular shaped curve, increasing in the US over time. This has also a relevance for liver transplantation, and paired kidney liver exchanges have been done as well. Another opportunity for the treatment of patients who have non-compatible donors and making a transplantation for those possible. Now, another aspect, I think, of which we're going to hear a lot about in the future is xenotransplantation. Xenotransplantation was out for many years due to the concerns that we could, in fact, transmit diseases with the xenotransplant. But xenotransplantation has made a great comeback, and that is predominantly through the potential application of the CRISPR-Cas technique and xenotransplantation. And there are centers in the US who are confident that clinical trials will be around the corner. Briefly, very short on aspects that I think are important when we look into the recipient immunology. Now, getting hit over the head is usually something that we remember, and it doesn't need necessarily a very elaborate adaptive immune response that has memory, but innate immunity has memory as well. In immunology, we had previously defined adaptive immunity with one of the very characteristics, which is that due to the elaborate way that the adaptive immunity is designed, that a second encounter with an antigen would then cause an immediate and more robust rejection. And we know that with accelerated rejections clinically, that this is very relevant. Not only adaptive immune cells, but also innate immune cells have the capacity to show memory, and that has now been shown in several studies for monocytes, showing here that they can activate dendritic cells, for natural killer cells, key players of the innate immune cells. I think there will be another aspect where we potentially can refine immunosuppression. We are dealing with the Me Too movement, and we have looked into aspects of sex discrepancy of organ transplants. Does it make a difference if an organ from a male donor is transplanted into a female donor transplanted into a male donor? And yes, I think both the Y chromosome as well hormones play a role, and there is another aspect, I think, if we more understand the entire interaction of hormonal interplay with immune responses as well, in order to be more precise with our immunosuppressive treatments. Hormones, estrogens, have interestingly both a protective, but then also potentially an acceleration of the immune response they may cause, and that depends on the level of estrogens that we see. So an interesting axis that I think we need to pay attention to, the hormonal immune axis moving forward. Now, something that got very in is the microbiome, and a lot of aspects in immunology, cancer immunology, transplant immunology, have been related to the microbe. The microbe as a shaper of the immune response. And this has been an interesting publication that shows the importance of the microbe. Koala bears that live in Australia, they're very picky eaters. They only eat eucalyptus leaves, and some of them are so picky that they are very much specialized in only eating a specific kind of eucalyptus trees. So there are some koalas that were close to distinction because they were not eating, and they were not eating their specific diet of the specific eucalyptus tree anymore, and they were resuscitated with fecal transplants. So they got fecal transplant that then did resuscitate their microbiome, and then they continued to eat well. The microbiome indeed plays a role also for transplantation. Those are data here from Mirza Allegre, where she could show that animals that were treated with certain antibiotics, eliminating their microbiome, did then have a change and a prolongation of their graft survival. So I think that will be a very interesting aspect for us to see moving forward, the context between microbiome and aspects of the immune response. But metabolism may not only play a role in regard to shaping the immune response. I think we also have an additional opportunity that we can use the metabolism of T cells, of immune cells, in order to change their immune response. And we have looked in a very early study that we have also, with an interest of aging both in the recipient and the donor, we have determined that an older recipient, an older T cell, has a different metabolism, and that this metabolism can be treated in an age-specific way. So overall, I think taking advantage and understanding metabolism of T cells and immune cells may provide us with new ways of treating recipients. So what are we going to do moving forward? I told you very early on that we have achieved so much. We have a lot of problems. We have a lot of good problems. I think we have to always think twice when we go back and work in the way that we usually work, and we have to think about this statement, which says that insanity is doing the same thing over and over again and expecting different results. And some of you may also think that they know the author of that, and it's falsely attributed to Albert Einstein, who'd never said that. Nevertheless, the statement itself is so interesting that we somehow naturally think, oh, that has to be someone very smart, and therefore we associate it with someone smart like Einstein. So we have to think, and we have to reflect on what we do, and we have to be open and available to do new things moving forward as well. So in conclusion, I think we have the opportunity to refine immunosuppression by understanding more of the complex alloimmunity. We may shift some of our interest to the graft, not only to the recipient. There are fantastic ways to assess and to improve the quality of organs available. There are new sources, hepatitis C, paired kidney exchange, for example, and xenotransplantation is always around the corner. Thank you very much.